mom. She's a really good doctor.
Hi, I'm Dr. Lex, but I'm also mom to Isabella, Lance, and Lucia.
Our mom takes care of our family, our friends, and her patients.
On this podcast, our mom is going to be talking to her doctor friends and teaching you how to keep your family safe and healthy.
Okay, Mom.
Ready for the show?
Let's do it.
Welcome to Family Health with Dr. Lex.
On today's episode, we are speaking with a dear friend of mine, Dr. Hajira Yasmin, also known as Dr. Yaz, who is a board-certified OBGYN with special expertise in sexual and menopausal medicine. Dr. Yaz has all the certifications as a sexuality counselor, a menopause practitioner, and has even completed a sexual medicine fellowship from the International Society for the Study of Women's Sexual Health. After 2 decades of practicing obstetrics, laparoscopic, and robotic gynecologic surgery, Dr. Yaz and her husband, Dr. Rajesh Patel, have opened a private practice here in Raleigh, North Carolina. There, Dr. Yaz specializes in the treatment of perimenopause, menopausal hormone balance, sexual dysfunction and pelvic pain in women, and restoring physical intimacy during survivorship after cancer. Dr. Rajesh Patel, her husband, specializes in treatment of the male partners of her female patients. And together they have created a very special sexual medicine and intimacy clinic that I know is going to help so many patients. Ladies and gentlemen, please welcome my friend, Dr. Hajira Yasmin, to the show.
I'm so excited that we're finally together face-to-face again. My friend, Dr. Hajira Yasmin, also known as Dr. Yaz, and we met virtually at first. And we finally got to meet in person last year when she first visited Raleigh, North Carolina, and we got a chance to show her around. But I'm so glad that we're here today talking about menopause and perimenopause and hormones and all things women's health, because there are so many people that I know who want the info, who need reliable resources to get good information and to know where to go, who to see, and what to do about perimenopause and menopause. So friends, please welcome Dr. Yaz. She's a board-certified gynecologist and member of the North American Menopause Society. Yaz, you're such a rock star.
Oh, hello, Alexis. I'm so excited to be here with you. And I am so grateful to have you in my life. I found you on virtually, but then you were such a connector. You were giving your whole heart and soul into this friendship. And I wanted to meet you and your family. So I ended up coming to Chapel Hill and met you, your husband, and you were so kind to show me around and really welcome me to this completely new city from another state. So I am so grateful to have your connection and support in my life. And thank you for having me today here.
Oh,
Super excited.
You are one of the people who women look to and want to go to and have in their lives, because you are such a wealth of information and experience when it comes to changes in women's lives surrounding perimenopause and menopause. And I find a lot of people go through the traditional road of doing the workup, trying to figure out what's the cause, what's going on, and how do I treat this? And they end up at a dead end. And so when I met you, I thought to myself, she's going to be such a valuable contribution to this community and to patients all around, not just in Chapel Hill and Durham and Raleigh and the Research Triangle, but virtually. You are going to help so many people with your model of women's wellness. So I want you first to introduce yourself and tell us a little bit more about why we should trust you. Why are you an expert in menopause and women's wellness? How did you come from a career in OBGYN to a direct practice delivering women's wellness in Raleigh?
That's a great question. I started my career in OBGYN in India. I moved from India after my basic education and training in medical school to England. I advanced my training in OBGYN in Birmingham and London. And I became a laparoscopic surgeon. I advanced everything there. And then I wanted to move to US to really kind of advance my training. That was another aspect. And the other thing was my family here. So I moved from United Kingdom to US. I did a full 4-year residency of OBGYN in a very premier institute in McGee, University of Pittsburgh. And I came out and I had a ton of opportunities because I was a practicing gynecologist in England. So residency was kind of a breeze. And I wanted to go to a small center and set up a full scope OBGYN practice, which I did in Wisconsin. I practiced as a generalist, delivering babies and also doing surgeries, removing uteruses and ovaries with robotic technology. I set up a robotics program. But I have to say, Alexis, during my career across India, United Kingdom, and United States, I found that I was lost to the answers of perimenopause and menopause. Like I would do surgeries, remove people like women coming in with ovarian cyst or ovarian tumors. I would remove them. I would take out the uterus, and then I would see them and they would tell me, you know, my sex is painful. I have vaginal dryness. I'm getting mood swings. I'm 44 years old. And you know, we didn't have that much of education or training in OBGYN residency and medical schools about menopause, perimenopause, or even that journey towards menopause, which we call now as perimenopause, or intimate issues like low libido, vaginal dryness, you know, I'm having painful intercourse. So these things really kind of piqued my interest as to why can't I help these women? I'm lost. Like, you know, when they come to my well woman visit. So I kind of took it upon myself and went and got certified and did a fellowship in Ann Arbor, University of Michigan in Ann Arbor, while my stay in Wisconsin. I was working full time as attending OBGYN, and I was fortunate to have wonderful colleagues, and I was able to go there and become a sexuality counselor. So I can understand human sexuality. I can really people with different sexual orientation, different gender identities, and how do I really approach with respect, professionalism, and different diversities, and how do I do that? Because that piece is essentially missing from medical education. So I became, and it was a 1-year post-grad course that I finished, and I got certified by the ASECT, which is a very credible body in our country about American Association of Sexuality Educators and Counselors and Therapists. And I also became an Ishwish Fellow. So there is a body called International Society for Study of Women's Sexual Health. And I sit on the advocacy committee and the membership committee there. So I just wanted to promote the education about sexual health and menopause. And then obviously you have to get certified by the NAMS, which is the North American Menopause Society. So here I am, triple certified. And I transitioned from delivering babies to doing surgeries into taking care of that woman from the age of 40 to however long. It could even be 90 or 100, as long as you're alive on this planet.
So I have so many questions. So it certainly makes you an expert. You remind me of when Marissa Tomei proved her credibility as an auto mechanic in My Cousin Vinny. She started to rattle off, you know, my brother's a mechanic, my father's a mechanic, you know, she went through the whole thing. Clearly you're qualified. Clearly we consider you an expert in menopause, perimenopause, and all things related to women's wellness, especially in the woman who is middle age and older. So I'm going to talk to you as a family doctor. I have a patient who comes to me and says, I feel like my hormones are not right. It happens 1, 2, 3 times a week. I will find someone who comes and asks me, what am I going to do about these perimenopausal symptoms? First of all, am I in perimenopause? Am I in menopause? How do I know? And what's the difference? And what am I going to do about these seriously life-altering symptoms that are really affecting my quality of life, maybe my mood, my work, my ability to be a partner or a parent, my intimacy level? How do you even start? Where do we start in the evaluation of a woman who complains of symptoms of potentially perimenopause or menopause?
The first thing in this scenario, Alexis, I would validate that because it is true. It is happening. I mean, that's the biggest problem I'm seeing in our healthcare systems because they are dismissed. Women are dismissed in a healthcare clinic when they walk in and say, I have mood swings, I'm frustrated, I'm putting on weight, I'm getting an occasional hot flash, and my vaginal dryness is killing my intimacy with my partner. We are like, Oh, this is all part of your menopause or perimenopause. Let's just do your pap smear and get you over to your labs. So, first of all, I would validate. And secondly, perimenopause is that phase where the ovarian function is declining. It is coming down in its trend. The estradiol is coming down. At the same time, we have these peaks. It's a very uncontrolled hormonal kick. Your hormones, your estrogen could be high. At one point, you could be low. They are those roller coaster peaks, and it's very hard to pick up with a blood test. I get a number of women in my clinic who come in and say, my OBGYN or my family doctor or my internist did labs, and they told me I'm not in menopause. Everything is normal, but I don't feel normal. I don't feel great. And what's wrong with me? So I typically do a blood test, but I don't go with that lab results at all. I go mainly with the symptoms that my patient is having, both mood swings and all of that. So it could either be that they may benefit from some low level, a low grade of hormones, low dose of hormones, I should say. It's actually a very low dose. I typically go for progesterone, like, not the estrogen. We'll talk about estrogen and progesterone, what it does in a little bit. But estrogen has got those peaks, but sometimes you put them on a low dose progesterone. So it is not a one size fits all solution. So I kind of look at them, I monitor their symptoms, I titrate the dose, and I also talk to them about some lifestyle support, because lifestyle support is so important, because what happens in your body, your ovaries are slowing down, but your metabolism is also slowing down. Your insulin is going up, your cortisol is going up with the stress that you're dealing. Your weight gain is happening due to a number of things. It's not just the ovarian hormones. You may not be sleeping well. You're not eating right because you're working like 100 hours a week. Or you may be grabbing a lot of food that's processed and it's not sitting right for you at that point. They may turn around and say, at 20 years, I was eating the same thing, I was doing the same thing, and everything was hunky-dory and fine. But no, you're 42 now. Your body's telling you this needs to change. So I spend close to an hour or 90 minutes with my patients who come in perimenopause or menopause, and I go through every lifestyle change, and I collaborate with other practitioners. Like if they need somebody like you, like lifestyle expert, I send them to you. If they need a dietitian, I send them to them, or maybe an exercise, or even stress management, like yoga or meditation, something to bring them back to where they were in their 20s and 30s. And then I balance those hormones depending on how they're feeling. They may just need a little tweak of estrogen, or they may need a little bit of progesterone. And very, very rarely I use testosterone, and we'll talk about that as well. I mean, that's another hormone that's coming into the light as to whether we should be using that. Does it have a role in women's wellness and health as they go towards menopause? So it's really a very comprehensive, detailed evaluation that's not happening in regular well-woman visits.
Absolutely agreed. There are so many patients that I see who come in and say that they have just been told that this is just perimenopause and it's a stage of life. It's not a disease, but yet there are so many quality of life conditions or stages of life that we have treatments for, and that we try to improve someone's quality of life. And so what you're saying is, just because you are going through the natural process of essentially ovarian failure, slow progressive ovarian shutdown of your ovaries as you get older, and you suffer with symptoms related to that change in hormones, does not mean that there is not a treatment, or that it is just a natural phase of life that you need to live with. There are treatment options. There are not only medication options, but there are a lot of other things that you can do to adjust for the changes to your hormone and your endocrine axis, because a lot of people don't realize or don't recognize that your pituitary and your thyroid and your adrenal glands and your ovaries, they're all in constant communication with one another. And when your ovaries are changing, so too are the other three endocrine axes. So you're absolutely right when you're mentioning things like sleep and metabolism and weight gain and insulin resistance. All of those things are also changing as our reproductive hormones, start to dwindle and start to fade as our ovaries start to decline and function. So I love that your approach is comprehensive, and I love that you're simply just validating that this is something that is real and that you are indeed experiencing and that you do not need to suffer with, and that one size does not fit all, that birth control pills are not necessarily the first or only step in the treatment options. I understand that there are a wide variety of treatment options ranging from dietary changes and lifestyle changes to natural supplements to different types of hormone replacement therapy. Yeah.
I want to add another thing, Alexis.
Yes, please.
We do not consider menopause as a preventative step. We always tell our women, why don't you suffer and get into menopause? And if you're really suffering, you can come back to us. We don't apply the same scenario for other things. You go to the dentist to get your teeth clean. You have a colonoscopy. You do all kinds of screening. But for menopause, we don't educate people. We don't tell you, okay, you're getting a hot flash, you're getting a night sweat, your metabolism is slowing down.
Yeah.
We need to make you understand what to look for. You're adding on weight. So there's no preventative checkups on menopause or perimenopause. And that's the big thing. That's the big change that I would love to see, the way we deliver healthcare for midlife women.
Yeah.
That needs to change in a preventative way, because what we're doing is just making women say, if you're miserable, come back to me, I'll give you hormones.
Right.
No, that's too late, because she's already lost a decade of her life.
Right. Yes. By the time you're right. We have tremendous amount of education surrounding adolescence. And of course, during childbirth and during the hormonal changes of pregnancy, delivery, postpartum, and breastfeeding, there's a tremendous amount of support and education for women going through those two phases of life. And you're right. It's kind of expected that we're just going to go through it. And when we get to the point where we can't take it anymore, that's when we're going to seek out help, instead of really preparing women for what to expect, but also laying out what are your treatment options going to be if this does affect you. Some women breeze through menopause and have minimal symptoms, or symptoms that they wouldn't really ever seek help for. And a lot of women really struggle with quality of life. It can lead to depression. It can lead to all kinds of other medical problems, because when metabolism is unregulated or out of control, then it can lead to other things like heart disease and diabetes, insulin resistance, which therefore increases our risk of all kinds of other deadly diseases.
Absolutely.
So we're here in your office. I'm 42 years old. I personally am not in the perimenopausal period yet, but I expect that it will be coming soon. My mom entered into it when she was around 39, or at least she blamed everything on menopause starting at age 39. Every time she forgot something, she would say, "Oh, it's menopause, leave me alone,"
I would agree with her.
So as someone who is potentially I could potentially be educated about what is to come and what to expect as menopause lays in front of me. What do you tell someone? What do you do to educate someone who has not yet entered menopause about what to expect, and what can I do in terms of treatment options before I start suffering?
I would really tell you to journal your symptoms. I would say be very close monitor of your body, your mind, and the way you feel in your mind. Are you feeling depressed? Are you feeling anxious? What is your body weight going? Is your waist size increasing? What is happening to your body? Just don't be in the rat race of life, but look inwards and see if you think things are changing in your body. And also your intimacy, you're developing occasional vaginal dryness. That's what I get in my 40-year-olds. Occasional intimacy is painful, like dryness. I'm using all the lube. I had a girl who told me I'm literally hanging with the bottle of lube in my hand, which is like, and you're 45 years old, you don't need to suffer that. So I will tell my patients, journal that. You don't need treatment right away. But if you think you're putting on weight, your mood swings are bad, your sleep is bad, you do these little tips that I tell them about the diet, the sleep, about 7 hours of sleep minimal, and 30 minutes of exercise every day. And with all of, and some kind of a stress management, like a yoga or a mindful practice, or even like 4 and 4 breathing. I teach that to my patients. Just do like an in breath for 4, out breath for 4. Even for myself, I do that. Like when I'm in between a lot of patients, I've got too much on my table.
Yeah.
I just take a break and I do that. And the reason we need that is we need your cortisol to come down. The cortisol is a culprit and it just keeps going up and up. So I give certain conservative plans for them. I tell them, okay, I'm not going to dismiss you for a year. I'm not going to just say, oh, just come and see me in a year. I'm going to bring you back more frequently. And then if the symptoms worsen, I will check your labs. I will do the entire 3 hormones, like the estrogen, the progesterone, and I also check testosterone, though I don't supplement testosterone before menopause routinely. So once I do that, I do about two or 3 times just to get a snapshot of the trend. Right. I just don't do that one lab and say, this is it. You're not in menopause. Forget about it. Don't see me for a year. I don't do that. I constantly validate. And if the numbers are showing me that she is entering those phases of low estrogen on and off, I will supplement that estrogen beginning with a very, very low dose. Now, mind you, some women are on birth control pill in that 42, 43 range.
Yes.
I try to transition them off the birth control pill into hormone replacement therapy. Because there is a difference between birth control pill and hormone replacement, because birth control pills are very high dose compared to hormone replacement. And birth control pills, majority of them are not bioidentical hormones. They are synthetic hormones that can slow your metabolism. It can increase your insulin resistance. Yeah. Your lipoproteins can all be, your lipid profiles can go haywire. So I try to switch them. Even if they are on a low dose birth control pill, I try to move them into HRT or hormone therapy. So it is very case by case. Very few people, I rarely send them saying, I'm not going to help you. There's nothing happening. Let me see you in a year. So it really depends on that person's risk factors. They could be having hypertension, they could be having diabetes, or they could be a cancer survivor, or they may be having fibromyalgia or some pain syndrome, or even thyroid issue. So I try to collaborate with your providers, like the other specialists, and I see that if everything is well controlled, is because, as you said, it's a play of hormones. It's a play from your pituitary to your thyroid to your adrenals. The ovary is not just going to act on its own like an isolated body. It is connected with all other actors around it. So we have to take a holistic approach to really give the best care to our women. We can't just be the fixers, or we can't just put a Band-Aid and say, hey, you know what? I'm going to give you some Prozac or an antidepressant, and I'm going to throw you on a birth control pill and see me in a year. So that's been the realm of our practice for regular mainstream OBGYNs, family medicine, internal medicine. But we got to move away from that and do a much more comprehensive, deep dive into women's health.
Yeah. When we have historically taken that approach, that cookbook kind of one size fits all approach, we end up with very frustrated patients. We end up with people who don't feel heard, who feel like their symptoms are not well managed. And like, really, you're putting on a Band-Aid on the wrong part. My mood is not broken. My mood is suffering because of my hormone system, which really is the system that needs to be addressed. So before we talk about the types of hormones and hormone replacement therapy that are available that you recommend or don't recommend, as someone who tends to receive more holistic, or patients who prefer a more natural route than medications typically, are there any treatment options that are not medication? A lot of people will ask about herbs or supplements or things that have been out there that they've read about from, well, who knows whether the resources that they're reading are reliable. Sure. But there's a lot of information out there about supplements and herbs that can help with menopausal symptoms. Do you think that they help? Are they safe? Do you recommend them for patients who are not necessarily interested or willing to do bioidentical or traditional hormone replacement therapy?
I do, because my approach is so holistic. I do go with certain vitamins and supplements as well, but I don't tell them to hang on to those things forever. If things
Okay.
are not improving in about 6 months, 4 to 6 months, or even 3 months, some of them don't have the patience, or, the symptoms are worsening, it's affecting their life. And they're like, Dr. Yaz, I've used it for 4 months and 3 months and nothing is working. I'm like, come on over, let's take care of you. So the typical supplements none of them are FDA approved. None of these vitamins or supplements are FDA approved for menopause, but I have anecdotal experience in my office, and many other practitioners like me have seen that by giving isoflavons, like, the isoflavons are the
Yeah.
good one, like you can use those. Evening primrose oil is another one, which I give, like it has got the GLA, the gamma linolenic acid, and that helps with all the hot flashes, the night sweats. Vitamin E is another good one because some of them have breast tenderness, like, that's again because of the hormonal chaos that's happening in your 40s. Breast tenderness doesn't come in my postmenopausal women. It mainly happens in that perimenopause. And I tell them vitamin E and your GLA and the evening primrose oil, isoflavons, and even red clover, black cohosh, and chasteberry tea. There are multiple teas. I mean, I tell them to bring their supplements to me when they're taking it so that I can read and make sure it's not adulterated, it's not got something else with it, and it's just a pure source. The other thing I always say is about vitamin D. Vitamin D is getting a lot of exposure, not just because of COVID, but it's being looked at again and again and again, as many integrative physicians are using it, and there's a lot of data coming out on vitamin D. I myself feel, I have taken that myself, and I feel like there is so much benefit from vitamin D. It adds that layer of vitality to my midlife women. So I always say about 1,000 to 2,000 international units of vitamin D. And vitamin B complex too, like the B1, the B2, the B6, and the B12, that it comes as a combination. So that is another thing I always recommend. Those are pretty much my standard supplements. And if people take anything outside of those, I just tell them, just be careful, bring it to my office, and we'll go through each one of them and see how long you can use. There is one thing about black cohosh. If people have stayed on it for years and years, I always test their liver function test, because there was 1 or 2 case studies where liver was affected with black cohosh, and I'm a little bit leery about people being on it beyond 6 months, 4 to 6 months. So I typically jump for some allopathic treatment with these people if they've been on supplements for 6 months or so.
So I've tried all the supplements and I've gone through 6 months that Dr. Yaz says I should try, and not much has really changed. And you say, come on, girl, we're going to really get rid of these symptoms for you. We're going to make all of the lifestyle changes, and we're going to talk about your options for hormone replacement therapy. That's a scary word, because HRT and hormone replacement therapy, both bioidentical and synthetic, have gotten a little bit of a bad rap. Maybe necessarily in some groups of patients, but more often than not, I think probably unnecessarily, based on the data and the research. So tell me about the hormone replacement therapy options that are out there, which ones are safe and not safe, and which ones you recommend in particular.
Yeah, I will start off from this study that came out about 2 decades ago, I think 2001 and 2002. It's called the Women's Health Initiative, that actually put the hormones in the doghouse.
Yep.
Because that study was mainly done on women who were 60 to 63 years of age. And the pill that was given was called Prempro. And it was a combination of synthetic estrogen and synthetic progesterone, which is progestin, actually, because it is synthetic. Progesterone is not. So it is called medroxyprogesterone acetate, which was the progesterone, and Premarin, which is the conjugated equine estrogen, which is derived from the horse's urine, was the combination in that pill, and they used it. And women suffered with breast cancer, stroke, heart disease, and clots, like clots in your legs, clots in the lungs. And so everybody, 80% of women in the United States were taken off hormones, pill or hormone therapy 20 years ago.
Mm-hmm.
But then we went back and a lot of good data came out. It was a flawed study because we studied older women. It was like 60 and above.
Yeah.
We had not given to women who were perimenopause or menopause. And the average age of menopause in our country here is 51. So we never used it in menopause. We didn't use it in the younger folks. Or we gave it to people who were above 60. And it was postulated that their arteries were already probably showing some atherosclerosis. They already had that layer of that fat. They had that layer of blockage that was there. And we just added something more to cause vasoconstriction and problems. And they may have had breast cancer cells because 63 and above, some of them were high risk for breast cancer. So NAMS, North American Menopause Society, came around and looked at these studies, and they put out a consensus to say a timing a hypothesis. There is something called timing hypothesis. So if you start a woman at the age of 50 or within 5 years of menopause, the menopause is the last menstrual period. Like, after that, you don't get a period for 12 months. That means you're in menopause. So, I mean, that's the banner of menopause, okay, right. You haven't had a period for 12 months. So somebody like that, if you start very early or even perimenopause, like if a lady comes to me at 45 or somebody like your mom who's like 39, 40, and she has not had a period for 12 months, we can start her hormone therapy at 40 or 42. But her risk factors don't increase till about 51 or 50 because we are just replacing her hormones. Mm-hmm. We are not like calculating. So I typically give about 5 years of hormone therapy or 5 to 10 years, and we started at younger women. So now what are the risks of hormone therapy? They're more with oral hormones, and oral are pills. And these pills, they go through your liver. And when they go through your liver, they increase your clotting factors. Right. And they are completely, they can increase your risk of blood clots. So we try to stay away from oral preparations. And I do not use oral estrogen. Almost 90%, I don't use those at all. I mainly use transdermal or vaginal estrogen. So we go through the skin or through the vagina. And transdermal, mind you, it is a systemic estrogen. That means it's still getting into your circulation, but the vaginal estrogen, very little is absorbed. Very little gets into your systemic circulation. So we'll talk about why vaginal estrogen is safer, and it is not even linked with breast cancer. I will say like vaginal estrogen should be the front label for every menopause, perimenopause woman. It should be pretty much like a vitamin.
So it works locally at the level of the vaginal lining to help with the symptoms of vaginal dryness, but does enough get absorbed to help with the other systemic symptoms of
Not really. So there are two things that it's going to help the vaginal estrogen. One is the vaginal dryness, painful intercourse, and bladder infections. Because the bladder sits so closely to the vagina. Like if there is estrogen deficiency, you have all the lactobacilli, the good bacteria in your vagina goes away, and you get all the bad bacteria. And your urethra, the opening of the bladder, can pick up all those bad bacteria like E. coli or everything that enters your bladder. So these women will come to you to say, I keep getting these urine infections after intercourse, or even without intercourse, even without intimacy, I keep catching infections. Yeah. So the first thing I do is look at the vagina, look at the anatomy outside. The other thing is, we as gynecologists, we don't focus much on vulva. So I have been trained as a sexual medicine gynecologist. I always look at the clitoris, the vulva, and everything. And if the labia minora or the inner lips, they become thinner, and the urethra, the opening of the bladder, is very prominent, and it's kind of looking inflamed and red, it's giving me a story. It's telling me there's not enough estrogen in her body, and she's the one who's going to benefit from estrogen. So vaginal estrogen, systemic estrogen. The other hormone that I also use in somebody who has uterus is progesterone. So progesterone is also released by ovary. And the third one is testosterone. And we don't need a ton of testosterone, unlike the males. We just need 1/10 of a dose. But that testosterone dose, what is circulating in our bodies, is higher in concentration than estrogen. So when you go in menopause, your testosterone is really in your boots. And we were not paying attention to this testosterone. Ishwish recently released a consensus statement saying we can use testosterone for postmenopausal women with low sexual desire or low libido. So it has been, it just, even in the Journal of Sexual Medicine, it just came out recently that it is approved for us to use testosterone in postmenopausal women. But then the premenopausal women before menopause, can you use testosterone for energy, for drive, for motivation, for your muscle loss? Mm-hmm. It's very off-label use. It goes on the comfort level of that specialist. Do I use in my practice? Yes, I do. I don't use as frequently as estrogen and progesterone, but if I have given you enough estrogen, I've given you enough progesterone, and you're telling me, oh, I still can't get up, I'm losing all my muscle, I'm going to the gym and I'm still losing it, I monitor very closely. So that's another big no-no about testosterone. People buy or go to some hormone clinic or anti-aging clinic, and they keep getting these excess loads of hormones, and they end up with adverse effect. In fact, even with high, you may be seeing this high hematocrits or even thickening of the blood or blood clots. They may be coming to the ER with hematocrits of 48 or a hemoglobin of 17 or 18 because they're taking high doses of testosterone. And these people can throw a clot. So it got a bad rep because these hormones do come with adverse effects, but you need to be tailored for your therapy by a hormone specialist or a menopause specialist.
So what is the monitoring that's involved when you monitor someone? Are you just reevaluating their symptoms and how well their symptoms are controlled or improving or not improving? Are you monitoring pelvic ultrasounds? Are you checking blood work periodically? What is the monitoring process to determine how and when to adjust the dosage?
That's an excellent question, Alexis. Yeah. So the first thing I do is when they come into my office, I take down all the symptoms. I examine them very, very closely. I also do something called vulvoscopy, which means I use a very detailed exam of the external structures of the vulva that we have, which is never looked in regular offices. Then we see for signs of deficiency, hormonal deficiency. Then I check their labs. I typically check for thyroid, prolactin. I also do check for estradiol, progesterone, and testosterone panel. And depending on their symptoms, if I replete those hormones or start them on hormone therapy, I usually bring them back every 4 weeks for the first 3 months till we know what's going on. I check their hormonal levels again in 6 weeks. So once I start the treatment, I check about 6 weeks. I mean, obviously, if they're out of town or something, 6 to 8 weeks for sure. Yeah. And if they're improving with the therapy that we are giving or the treatment that we are doing, then I give another 6 to 8 weeks to see how they're doing and check them again in 6 to 8 weeks. So about 2 labs separated by 6 to 8 weeks and about monthly appointments for about 4 months. Okay. Once they are stable, then I space them out by about 4 months. I see them in about 4 months. I don't need to see them monthly. And then I keep them on a close, they will call me and they are able to communicate directly with me. I've got this, I felt a little sleepy with this hormone, or I went to bed early, or I felt a little dizzy, those kind of little support and ongoing support. They don't have to call a PA or a nurse or an MA, or, they can reach the doctor directly and say, I've got this is my dose. Can you help me? What's going on? So that's how I tailor that. And each person's, if I pick up my patient's charts, each person is so different and hormonal doses are very different.
And because of the way you practice, your patients very well, and you probably could answer the phone and just make dosage adjustments based on knowing the patients, just knowing them and their history well. Talk to me about bioidentical hormones. What does the word mean? Is it safe? How does it differ from traditional synthetic hormone replacement therapy?
That's a great question. It got a great rep. I think many celebrities kind of made it very popular, bioidenticals. I think somebody wrote a book, if I don't remember top of my head who that was. Bioidentical means the molecular structure of that hormone is similar to what your ovary is making. So it's exactly like if they are making an estradiol in the lab. Now, mind you, this is not made somewhere in somebody's body and put in you. It is made in the laboratories. But that molecular structure is exactly like your ovarian estradiol. Like, when you are in your 30s and 40s, what you're pumping out of your ovaries, that structure resembles this, unlike these synthetic hormones. So that's all it means. It's just identical. Now, the second difference is the synthetic hormones, they use all different kind of compounds to make it. The source of bioidentical is plants. So they use soy and yams. Those are typical, those are the mainstream stuff. The third thing is, I wouldn't call that 100% like, if you take bioidenticals, you're going to be safe. You're never going to get cancer or, heart disease. It has the same risk. But no, we don't have long-term data. We don't have studies to say just because this is coming from plants, plant source, this is 100% safer. So I do use a lot of bioidenticals because in my practice, in my anecdotal experience, my patients get better relief of symptoms. Like if they have hot flashes, if they have, vaginal dryness, or if they have any kind of a systemic symptom, they get a very rapid relief with bioidentical. The absorption is better. I don't have to keep giving them higher and higher and higher doses. So I get away with the lowest dose for the shorter amount of time. So I do use bioidentical, but we still have to be very safe and tailor it in a very customized way.
So the word bioidentical essentially just means that your body doesn't differentiate between the hormones that your body makes and the bioidentical hormones that you're taking because the chemical structure is identical.
Absolutely.
Bioidentical.
Yes.
So are there bioidentical hormones that are FDA approved? And are there, in situations where you want to prescribe a bioidentical hormone, but say, for example, it's not covered by insurance, are there synthetic hormone replacement therapy options that you consider safe and prescribe for your patients as well?
That's another great question you're hitting, Alexis. So that's awesome. So they are bioidentical FDA approved options. We have estradiol patch, it is bioidentical. Micronized progesterone is bioidentical. They're all FDA approved. And I always tell my patients, these are branded products. They are made in the drug companies and FDA has approved that. So we try to stay within these products, like as you said, if their insurance is not covering them, or, they're telling, oh, this is $300, it's too expensive for them to sustain. Because if it is $300, what does my patient do? She's going to use it for a month. And then she's going to say, oh, this is not sustainable for anybody's long. We outlive our ovaries. We live beyond our ovaries. Our ovaries stop at 51 or 55. We live till 88. Our average age life expectancy is 85, 88 in our country. So what do you do for those 4 decades or 3 decades of hormone therapy if it is $300 a month or $400 a month?
Yeah.
So what I rely on compounding pharmacies. And compounding pharmacies, I literally vet them. I go to the pharmacist, I see how they make, and most of the ingredients are FDA approved. And I depend on them. I talk to the pharmacist, the manufacturing stuff and everything to make sure this is coming from a good source. They're using the plant products and it's not something synthetic. And then I do get progesterone and estrogen from compounding pharmacy for patients. These are almost like maybe less than a branded product, maybe half the price or 1/3 of the price of branded products. And that is sustainable, depending on the plan, we are weeded into a healthcare system with so many insurance plans and so much of coverage. I just spoke to a patient this afternoon. She was telling me her estradiol is so cheap in her coverage, but the next one was telling me, oh my God, it's so expensive. Can you give me another option?
Yeah.
So I try to stay away, coming to your question, I try to stay away from synthetics. I try to stay with the bioidentical. Because we have not got any bad studies. We don't have long-term data about stroke, heart disease, breast cancers with bioidenticals because it's a plant source. And there are some small studies that say most of the experiences have been good for patients with bioidenticals. So I'm a proponent of bioidentical hormone therapy. And I try to pick up the FDA medications, but if I can't, I rely on compounding drugs.
So just because something is bioidentical does not mean that it has not been through FDA process of being approved and being tested.
True.
Excellent.
True. It is.
Yeah,
It is approved and it is available.
I think that's a common misconception. People think that the bioidentical medications are something that's holistic or alternative or comes from a source that we aren't familiar with or that hasn't been necessarily tested. And essentially what you're saying, just like we talk all the time, is that everything is a risk versus benefit decision. You have to take into consideration overall, what are the risks of taking a medication, any medication, ibuprofen, aspirin, they all come with risks, vaccines, everything comes with a risk. What is the balance of the benefit of taking something over the risks associated with it? And are you maintaining and keeping up to date with your routine healthcare maintenance? Are you screening for breast cancer and colon cancer? Yeah. Are you doing all the right things? And if you are taking a medication that's making you feel good and that's improving your quality of life, and you're maintaining your screening protocol per your primary care physician, you are doing all that you can. And the risk in that situation overall in an average person is probably negligible. It's probably safe enough for us to pursue. So it's very hard to banish and to dispel the myth that hormone replacement therapy is not FDA approved, that it's holistic or alternative, that it's not safe, that it causes cancer. Those ideas, those rumors, those myths have been long-standing. Yeah, they've been longstanding. They're tough to overcome. There's a lot of fear surrounding hormone replacement therapy, especially in patients who have cancer. So I want to ask you about how you feel about prescribing hormone replacement therapy for someone who has, say, for example, had breast or ovarian cancer and has been in remission and recovery and is cancer-free and has symptoms because they've had their ovaries removed, has symptoms of menopause or perimenopause and want to improve their quality of life as they well deserve. How do you feel about that? Is it safe? What are we looking at in terms of data?
Yeah, I would like to endorse your point before I go to this question, Alexis. What you did say about hormone replacement therapy and risk factors, we have to look at a bigger bubble of evaluation, your risk factors in a bigger perspective. Because when I get patients who tell me I am afraid of hormone therapy, I mean, we got to see a safe hormone therapy that is monitored by a menopause specialist. That risk factor is much less than a glass of wine, or even say, yeah, exactly. Even, taking a daily glass of wine, like everyday glass of wine, or even your body weight. We have to evaluate. And as you said, as you rightly said, every medication comes with risks. There is no medication on this planet that any doctor is going to tell you, hey, this is 100% great, you can take it. There's no zero risk. So I would want women to explore. The second thing is that there is a lot of myth. There's a lot of fear. There's uncertainty. The reason is we haven't done a good job. We don't educate our women when they come through that postpartum phase or through that phase of women exams after 35 years of age. We don't educate them. We don't tell them this is normal. This is normal aging, normal, graceful aging. This is your ovaries are going to stop, but you're going to live about 2 to 3 decades after that. And you can seek help. So there are patients in my clinic who come in and say to me, I want to do this naturally. I really want to do this menopause naturally. And I am totally in line with that. I tell them that's fine. Write down your symptoms. If you think every day you're getting these symptoms and your quality of life is not up to the mark, and you're not sleeping well, you have terrible anxiety, and you're struggling, you don't need to get a medal for that. You don't need that kind of a natural change. You should seek help in today's world because we have options. So that's my big message that I want to do. And then I'm going to touch on your question about cancer survivors.
Yes.
Cancer survivors, they do get symptoms. And I was taking care of a lot of them in Wisconsin in my intimacy clinic, which I ran in Wisconsin. And I'm trying to do that the same here. I mean, I've just been in practice here for a short time, but that's my long-term goal, to take care of this unique population whose intimate needs we are not looking at it. So I have managed a couple patients so far. I collaborate with their medical oncologist, and if they are in remission, if they are on medications like tamoxifen or anastrozole or something which is an anti-estrogen, I am comfortable giving them vaginal estrogen. Now, mind you, I will talk to their oncologist. I pick up the phone because I have the time to collaborate with that oncologist. Like I have spoken already to about 2 or 3 people in UNC, and I talk to them and I say, can I give this woman, because I've looked at her vagina. I've seen how much she's suffering. She's got urinary infections. She's got pain just to sit and ride a bike. I mean, she's not even sexually active, even to just like ride a bike or even to run. You know, there's so much inflammation happening and the yeast infections and pain. So there is so many things happening, and I'm more than happy. And as I said, there are more and more data coming out that vaginal estrogen is safer at a very low dose even for cancer survivors. And I collaborate with their medical oncologist, so my patients are comfortable that their oncologist knows that they are on hormone therapy.
So making sure that there's complete transparency, that all members of the team, providers and physicians who are taking care of the patient are all on the same page and are aware of what's going on. Because a lot of times, especially when it comes to things like supplements or things that are off label, things that are not necessarily FDA approved, I find that a lot of people are just, they don't bring it up, or they won't talk about it with me or their other physicians because they think they'll be shamed, or they think they'll be judged, or they'll think that because they saw something that was not a traditional medical therapy that we won't approve. And yet, when we have the information and we can collaborate and communicate with the other physicians, we can come up with a plan that everybody is comfortable with and that uses the least amount of medication, that is effective and safe for an individual patient. I think the point to drive home is that this is so individualized and should be so personal to your particular risks, your particular symptoms, your age, your risk factors. And I don't think that any kind of cookie cutter, one size fits all prescription for any medication, but is effective, but in particular for hormone replacement therapy.
I cannot agree more than that. You know, Alexis, that's you nailed it. That's exactly my message to everyone. It has to be a customized, individualized plan that we have to lay down and monitor you very closely. I mean, even with 1 picogram of hormone in your circulation, how are you showing up? How are you functioning?
Right.
You know,
And
so,
you make a great point that we have not done a great job of being communicators of information that could potentially benefit patients. You know, we may not be educated enough. We may not have the support and education and information that even we as physicians need. We've been through medical school. We've all done the OBGYN rotations, but is that enough? Is that enough at this point to be able to care appropriately for special populations like a menopausal woman? And in OBGYN training, is there enough of an emphasis on the care of the aging woman, menopause, perimenopause, with respect to what are the treatment options, what does the evaluation look like, and how to go about educating us, because it's critical. Now, I know that you're a doctor, an OBGYN, you are a vagina doctor, you are a women's health expert. But I'm a family doctor and I couldn't imagine a practice without taking care of men. So I do want to ask your opinion on where do the men fit into this? Because there's such an emotional connection with your physical changes, and they're so related to each other, and they're so interdependent that I want to ask, and not even necessarily just about men, but partners. How can the partner, whether it's a man or a woman, how can a partner of a woman who's going through menopause, number one, be supportive, and number two, is there any need for a medical workup for the partner as well?
That's great. That's great question, Alexis. Yes, there is absolutely. I always try to tell my patients to bring their partners for consultation. And even if they don't want, some of them don't want them for the exam, but I do talk to them after the exam is completed. And I tell them what I have seen and what is going on. So that validation that there is a change happening in the woman's body around 40, 50, 60, doesn't matter. I think that's very powerful, because for your partner to know that what you are going through is valid. It is something that you are facing. It's normal part of aging, and that will happen. That phase will go through. So awareness and education, same of the partners as well as just like our patients. So we try to tell them what is happening, what kind of treatment I'm giving, and how long will it take to improve. And when the urine infections go away, vaginal dryness goes away.
Yeah.
The other piece is I have patients who will come to me and say, you treated my vaginal dryness, everything is good with me, but my partner has this erectile dysfunction or premature ejaculation or some other problems relating to diabetes. So fortunately for me, I have my husband who's an internist, and he took care of a lot of men with these issues in our prior practice in Wisconsin. So he comes in as a part-time doctor, internist for the male partners, and he will treat them. And in the same center, in the same space, which is safe, we don't have to refer them elsewhere. And sometimes urologists don't have that kind of time because they're so busy with prostate and kidneys and stones. So Dr. Rajesh partners with me, and we have set up this intimate health center where we can take care of my women and their male partners. So that is kind of a neat center that we have created, a safe space for a couple to receive their care.
Yeah, it's so beautiful. I mean, really, truly, in what specialty is someone taking care, other than maybe counseling, psychiatry, marriage therapy, in what specialty is the partnership, the couple, the intimacy being addressed? Because you oftentimes have the one person in the room, and there are so many cultural, religious,
social
norms and beliefs that may or may not be true, and that may be affecting how partners relate to one another. Perhaps if they're, two female partners, one of them is experiencing menopause and the other is not. Perhaps a male partner to a woman who's in menopause, is in an attempt to be considerate and gentle, maybe, in a sense, making her feel more shame or embarrassment about her condition, So I think it's beautiful that as a female physician who takes care of women's bodies and minds, that you have the advantage of having your husband who can help men, and that you are an intimacy counselor and you have the knowledge base, the language, and the tools to take care of a couple, to take care of people who are involved in an intimate relationship that might not be ideal for them, and help them work on their physical health to get to that ideal state, and to help them work on their emotional connection, their emotional intimacy as well, because that too is such a huge part of what makes us human and what makes us whole and what makes us healthy. So I so value everything that you bring to the field of OBGYN, everything that Dr. Rajesh Patel brings to internal medicine and men's health, and the way that you approach your patients, the treatment options that you offer, and the gentle and loving manner that you provided. I just think you are an absolutely invaluable member of this field, and our patients, I'm certain, are going to love you in this area and beyond as you help people with via telemedicine. So as we close out, I just want you to let my friends know where they can find you and Dr. Rajesh, and on social media and in person, so that we can continue to cross-refer patients and continue to let our wonderful patients who are in the middle of their lives continue to experience sexual health, intimate health, and wellness for the rest of their lives.
Thank you, Alexis. Thank you. I feel really grateful to have this opportunity to serve women. And women can find me, and their partners can find Dr. Rajesh at our practice at www.alraymd.com, and they can contact me through my website in the contact form. And I am also on Instagram at Yasmin, Yasmin, Gyno, MD, GYNO, So they can message me and ask me if they have any questions. So I would be happy to take care of them or answer any questions for them.
So wonderful. Thank you so much for being who you are and doing what you do. I can't wait to see you and hug you in person. And thanks for being here today.
Thank you, Alexis. Thank you for having me. It was
Bye,
fun.
Dr.
I enjoyed it. Bye.
Mwah.
Oh, you're so good.
Hey, thanks for listening to my podcast, Family Health with Dr. Lex. If you love the music like I do, you can find more at therealmichaelvm.com/music. If you'd like to support the show, please leave a review, subscribe, and share with your friends. You can ask questions, suggest topics for future podcast interviews, and find more health and wellness information on my website, drlexlifestylemedicine.com. See you next time.